Hello, and thank you so much for joining us today for the webinar Innovative Regenerative Therapy Approach, LPRF. It is a great pleasure to introduce to you Professor David Dohan Ehrenfest. Professor Ehrenfest is currently the director of the Low B5 Unit, Research Center for Biomineralization Disorders, Konam National University School of Dentistry, South Korea. After his studies in Paris University, he worked at the University of Paris, France, the University of Gothenburg, Sweden, and the University Federico II of Naples, Italy. He is the author of more than 200 articles in the fields of periodontology and implant dentistry, and the editor-in-chief of the International Possedo Journal. His centers of interest are particularly the various applications of platelet concentrates and the development of new implant surfaces, design and bone materials. We'd like to thank Professor Ehrenfest for being with us today, and botiss for making this lecture possible. Please take note of any questions and comments you have during the lecture, as they will be addressed by Professor Ehrenfest at the end of the presentation. Without any further delay, please help me welcome the expert himself, Professor David Dohan Ehrenfest.
Hello, everyone. It's a pleasure to be with you tonight. And I will do you a presentation about the leukocyte and platelet-rich fibrins, the LPRF, and this new approach and new therapies of regenerative medicine which are related to this material. This presentation will be mostly based actually on the publications on the topic to show you both the history, the basic science, and the first clinical applications of this material. So, when we speak about PRF, we have in general to speak of platelet concentrates, because this is a much wider family that you probably heard about already, the PRP, the PRF. And when we speak about that, you hear a lot of big words like growth factors, regenerative medicine, stem cells, magic also sometimes. And this is a little bit the problem of this field, is that a lot of big words, of big concepts have been launched, and it is very important to have a clear vision of what we are exactly talking about. With two questions. First, what are exactly these products? What are exactly platelet concentrates for topical and infiltrative use? And second, why do we use them? What is really the objective? It will be the first step of this presentation. First, what are platelet concentrates? All these products, the LPRF, but also all the others, are autologous blood extracts. It means that blood is collected and centrifuged, whole blood is centrifuged in order to extract platelets, plasma, and a lot of possible cells, molecules present in the blood. So it is first of all a blood extract. Here on the picture, you can see two kinds of family of product. Here, for example, the PRP suspension, which is a GPS from Biomet system. And here you have LPRF clot, which is mostly what we will speak about today. But in fact, all these products, even if they look very different, are the same family, the platelet concentrates. The second is, why do we use them? All these products have as an objective to improve, accelerate soft and eventually bone tissue healing. They are placed on a surgical site or a wounded site to improve the healing. And this is quite a natural process because this is the effect of fibrin and the platelet growth factors to promote this healing. The second level of expectations is tissue regeneration. And here we call more in application in oral and maxillofacial surgery, but also sports medicine, orthopedics, and many other medical fields. Here on this picture, you have a classical application of PRP on a skin wound, for example. It's a post-surgery to improve the healing of the scar. Here, you see how it looks like. It is a PRP injection. But it is also this kind. Here you always have the reference for all photos I'm showing is a reference where it was published by, in general, all of them by me and my group. Here you have PRF applications where you can see the PRF membrane put to cover the Schneiderian membrane and to cover a sinus lift. So you see many different potential applications, but always the same. It must be, it is on a wounded site or on a surgical site to improve healing or to promote tissue regeneration. These products have in fact a very long history. As you can see, it started, in fact, the term PRP was first created in hematology in 1954. And we can really put the beginning of this surgical adjuvant in the 1970s with Matras, who was Austrian, and who developed the first fibrin glues to try to improve soft tissue healings. It was the idea of using fibrin to improve healing. A few years later came all a generation of product called platelet fibrinogen thrombin mixture, or platelet gel. And they were tested with success already a long time ago, as you can see, in ophthalmology, general surgery, and neurosurgery. It was the first PRPs. It's very old. In 1986 was also a series of publications about the treatment of skin ulcers with platelet-derived wound-healing factors, what was termed in that time PDWHF. But really, the craze for growth factors really started in 1997 and 1998, particularly with the publication of Marks from Florida. And this is really at this moment that was a huge development in oral and maxillofacial surgery of the PRPs. So as you can see in the long history of this product, it started like a fashion. First, we started to speak about fibrin, then platelets, and now we only speak about growth factors. While it is actually obvious that these PRF and PRP, all these products, are in fact tissues. They are an ensemble of fibrin, the matrix, platelets and leukocytes, the cells, and growth factors and all kinds of cytokines. So the history of this product explains you a little bit many evolution of the industry in this field, but you always must remember that they are tissues, an association of fibrin, of platelets, and of growth factors. So to try to clarify this problem, we published in 2009 a classification which is now one of the most cited articles in the field. And this is, in fact, an article where we separated all these platelet concentrates in 4 families depending on only 2 parameters, the fibrin architecture and the leukocyte content. In short, the kind of matrix and the cell content of the product. In these 4 families, it was 2 kinds of PRP, pure PRP or leukocyte PRP. I will explain in detail just after that. Or 2 kinds of PRF, pure PRF or leukocyte and platelet-rich fibrin L-PRF. It is from this classification that the term L-PRF appeared. You see, it was in 2009. Here you have an illustration of the 4 families. It was from this article. Because 4 families means 4 different architecture. Here you have the pure PRP. As you can see, there are no cells because there are no leukocytes. And you see that the fibrin network, this very light yellow network, it is very slim. So this is the characteristics of all PRPs. They are in liquid solution or in activated gel form, but they always have a very light fibrin network. When they have cells, they are LPRP, leukocyte and platelet-rich plasma. Here they have in blue cells. They have in white the platelet aggregates, like both. And they have also this very light fibrin network everywhere. So here in the upper part, you have this 2 PRP family, platelet-rich plasma, which are liquid solution or activated gel form. In the lower part, you have the 2 PRF kind, the pure PRF without cells, or the L-PRF with cell, leukocyte, and platelet-rich fibrin. And with the L-PRF, as you can observe, it is always a very strong fibrin network with this very strong fibrin mesh. In blue, you have the leukocytes, the many cell population in reality. And in white, you have the platelets aggregate. And what is very important is that these PRF, these 2 kinds of PRF families, in fact, there are many versions possible, PRF families only exist as a strongly activated gel form per definition. That's maybe the best separation difference between the platelet-rich plasma, the PRP, and the platelet-rich fibrin, the PRF. Now let's speak only about LPRF, as it is the main technique used nowadays in oral and maxillofacial surgery. The concept is very easy. It was developed more than 15 years ago, actually. The blood is taken without anticoagulants and immediately centrifuged in this kind of tube, 9 milliliter or 10 milliliter. And during the centrifugation process, we obtain 3 layers. At the bottom, the red blood cell, RBC. In the upper part, the platelet pour plasma, PPP, which is just a kind of light serum. And in the center of the tube, the PRF clot, platelet-rich fibrin clot. This is what you can observe here on this photo. The red blood cell, the PRF, and the PPP. When you do your PRF protocol, you observe a specific quantity of platelets and leukocytes. It was published in this publication in 2010 in the Journal of Periodontology. You collect most of the platelets of the initial blood harvest, 50% of the leukocytes of the initial blood harvest, a majority are lymphocytes, this is very important, and a very high density fibrin architecture which explains the quality and the strength of the membrane. The main system available to produce PRF actually is the only official certified system. It's the Intraspin L-PRF, which is the CE marked and FDA. This is in fact the original method we are using since the beginning, just with a commercial name. But there exists also a lot of what I call PRF-like variations. For example, you have TPRF. I don't know if you heard about TPRF, but it means titanium PRF. It was an experimental idea to produce PRF with titanium tubes, but it's not marketed, it is just experimental. And there are like that many PRF-like variations. But in fact, the technique I will speak about is the one we are using since the beginning and who was tailored very carefully and now exists as Intraspin LPRF. Here you can observe a classical LPRF kit. You have a small table centrifuge. The quality of the centrifuge is very important, as you will see in the next slides. You have here the box to collect the sample, scissor, pincet, some instrument to manipulate the membrane and clot, and here's the tubes. It is a very simple and inexpensive, actually, and very easy to handle material. And this is what we published in 2010. With this very simple material, you can see a lot of these kind of clots. These clots are something like 3 to 4 centimeters long when they are produced correctly. And you can really obtain a lot. Here, this picture is was done for the purpose of the publication and is very impressive with 16 clots. But in general, we produce by 4 or by 8. It is much easier. But you see, after compression of this clot, you obtain these very strong membranes in the box. And these membranes have a lot of potential interesting applications. So let's analyze a little bit in detail the content of a PRF clot, or LPRF clot. This was published in 2010 in Journal of Periodontology. In fact, when we do photonic microscopy of this clot, we observe that on the red part here, there is always a small reddish part at the top that you must peel very carefully. You should never cut it, actually. In fact, in this transition period, in this transition area, you will find what we call the Buffy coat. It means where there is the highest concentrations of cell and platelets. Actually, the platelets are activated and present all over the membrane, but this is really here that there is the highest concentration of cells. And when you do a photonic microscopy of this clot, you will observe these veins here. See, is in blue all these spots, which are all the cells and the aggregates you can find in this area. And you can after differentiate them, different kinds, using a different staining, particularly all forms of leukocytes, circulating stem cells, etc. But the body of the fibrin matrix is also rich in many things, as we will see in an instant. If we analyze this clot in scanning electron microscopy, what was published actually in 2000 and also, it is the same article, we observe in the upper part of the clot red blood cells. This is what you can observe here. The red part is in fact mostly a very light fibrin network with some residual red blood cells. This is when you go a little bit deeper in the clot, that suddenly you start to observe, you see here you have still your red blood cell, and very quickly you start to observe these lymphocytes everywhere. And the deeper you go in the clot, then you arrive in the veins where you have these very big platelets aggregates everywhere. When you analyze your membrane, you have this aspect. As you can see, this is a very strong fibrin network, a very strong matrix actually, where the fibrin gel is like cemented by platelets aggregates. In the natural process of coagulation, the platelets aggregates serve really as cement of the fibrin network, and this is really what you can observe on this picture. When the clot is compressed into a membrane, here you can see that, it becomes a very, very tight matrix. Here you see the fibers all over these pictures are like completely compressed and completely compacted. So it shows you why this membrane is so elastic and efficient and strong when you manipulate it. It is simply related to its very strong fibrin architecture and polymerized architecture. So here is what is a LPRF. You have understood, you have your cells in blue, you have in yellow this very big thread of fibrin, compacted, and in white, these platelets aggregate cementing all of it. Now, what you have to understand is that there are on the market and in the literature thousands of PRP and PRF types because everyone was trying different variations, like we did actually at the beginning. And the problem is that each product has really his own identity, what we call the biological signature. We did a series of publications about that, where we try to compare different kind of PRP and PRF, I mean, those who were significant in our practice, and to try to see what was really released by this material. For example, these results were also published in one of the articles I just cited. We try to compare the growth factor slow release from these kind of membranes, PRP or PRF membranes, during 7 days. We try to evaluate what we call the biological signature of each product. So in the first study, we compared LPRF membranes and another kind of product which is quite frequent or still available in oral and maxillofacial surgery called the ubiquitous PRGF, a plasma rich in growth factor or preparation rich in growth factor, also called Andorette. This PRGF is in fact a kind of PRP. It means that it exists mostly in liquid solution, but it can be transformed by forcing it a little bit into a membrane, and actually this company is also pushing to do that. So here you have on the picture the two machines. This one is for PRGF. You see that it can be very cumbersome. This one is for LPRF, the traditional machine we use since 15 years. After production of the clots using the same quantity of 9 milliliter of blood, we have one LPRF membrane, and we have one PRGF and one PPGF membrane. This requires several steps of pipetting, several steps of warming the membrane in a small oven to reach this membrane. So it's not user-friendly at all, but with the same quantity of blood, we produce LPRF membrane and PRGF, PPGF membrane. We place this membrane in culture at 37 degrees, and we made the quantification of the main growth factors and key molecules at 20 minutes, 1 hour, 4 hours, 24 hours, 3, 5, and 7 days to evaluate the release of TGF-beta1, which is a major growth factors for healing, PDGF-AB, which is a platelet growth factor very important for the proliferation, VEGF, vascular endothelial growth factor, very important for the neoangiogenesis, thrombospondin-1, which is an important molecule for coagulation and early healing, and also fibronectin and vitronectin, which are glycoproteins, which are very important for the efficiency of any matrix. And we observed these curves. It was very impressive to see that in all cases, here it's for TGF-beta1, here it is for VEGF, the cumulative quantity of growth factor released by the LPRF membrane was always much higher than the one released by the PPGF, by the PRGF. Here it's LPRF, here it's PRGF, so this PRP. Same thing here, LPRF, PRP. And it was the same also for other molecule like PDGFAB with a smaller differences, you see, still very strong, L-PRF and this PRP, this PRGF. And here for fibronectin, L-PRF and PRGF. So what this graph is proving is that each growth factors each product, in fact, first of all, PRF, PRP, etc., has its own biological signatures. And one of the main markers is the quantity of growth factor release. There are considerable difference between the products, and this is why they have different applications. Somehow, this result I just show you maybe participate to the explanation of this statement. Each PRP and PRF will have different characteristics and will have different applications. If you start to use it, you will see that LPRF fits completely the application in oral and maxillofacial surgery because you have membranes or clots with a significant volume, with a strong material, with a slow release. It is easy to prepare in large quantity, it is inexpensive, and this is why it is developing without any efforts actually in our field. However, you should remember that the PRP gels are very interesting substitution to fibrin glues when you are using it in a surgical site. This is what we see here. You see, wound dressing with injectable PRP is a way to improve the healing of this scar. And also, some PRP solution may be very useful as injection in sports medicine. They are injected like pharmaceutical solution. Here, for example, you see PRP injection into a quadriceps tendon. It is very fashionable in this moment. And there is one last application actually of the PRP, which is one of the oldest applications. This is the gelling of bone materials with injectable PRP. It is, you see, here you have your PRP and the activator. It is placed on the bone substitutes, and it makes a jellified material. However, all these applications are applications of PRPs. And in the case of LPRF, we have another advantage, which are very strong and very strong membranes with a significant slow release. Now, second step, what are the differences between the various PRF variations? Because as I explained you, each time you change a little bit the protocol or the machine or the tubes, you may change your product. So we did a study, which will be soon published, where we compare the different centrifuge, different tubes, and variation of protocols to see what happens. Here on this picture, you have 4 machines that were placed in this study. The first one, this is the original LPRF machine that is used since 15 years and is now under the name Intraspin CE and FDA marked system because the system had to be certified. It is a machine made in Germany actually, and this is we have been very lucky to have this machine since the beginning. Then we have other variations. So first the APRF machine, which is a not certified system actually and made in China. We have the Salvin PRF-like protocol, which is something sold in the US, but in fact it is not authorized material for PRF, but it is sold by some company to do something with it, but they don't say what because it's not a certified. It is also made in China. And also you have the LW scientific PRF-like protocol, also another machine sold in the US, which is in fact also made in China and USA, and which is also not a certified system. So we try these different machines to see if the kind of machine, first of all, has an impact on the kind of PRF. First, in the first article, it is a series of 3 articles, we evaluated the vibrations of centrifuge at different speeds. Here you see, you have 5 machines actually. I show you only 4 because the last one actually was not incorporated in the final article. And you see here, in terms of vibration, the one we had since the beginning, this old small German machine we had in 15 years, was the one who had the lowest vibrations, whatever the speed. While in fact, other machines who appeared after this first German machine had always much higher vibration. For example, the LW has a very strong vibrations when we reach particularly these 2,700 RPM. The APRF machine is also even higher. And the Salvin here has only 1 speed and is very high in terms of vibration. So first of all, and this is something that has never been published before, for each centrifuge has a different profile, particularly in terms of vibration, and this vibration may have an impact, and no one will tell you that. And what is this impact? We come to the part 2 of this series of articles, the evaluation of the clots and membranes composition, the fibrin, the cells, using a macroscopic evaluation, photonic microscopy, and SEM detail analysis. You see, this second article is directed by Dr. Pinto, which is a wonderful researcher in the field. So we use the same for machine and we prepare the clots. And here we have the aspect with SEM of the 4 kind of PRF we could produce with these machines. With the original intraspin LPRF, the original LPRF method, you observe that you have the cells alive. All the cells are in perfect shape, you see? The lymphocytes are round, the MSC are a normal shape, the fibrin network appears okay. I will show you more pictures just after that. But for other machines who are vibrating, which are vibrating much more, for the LPRF variation, for example, all the cells are damaged. It's impossible to find cells in normal shape in all the clot. If you use a PRF-like salvin again, all the cells are like completely shrinked. It means the shock of the vibration is like simply making the cells exploding or shrinking. Same thing with the PRF-like LW. So this very obvious observation when we put the clots in SEM confirms that there is a parameter, the vibration at least, who is significantly impacting the quality of the clots. Vibrations is killing the cells, and vibration shall not be neglected. And now if you compare, for example, a bit more in detail, the original LPRF with the LPRF variations, you see that here you have your cells in perfect shape, and you have this very strong fibrin density. But if you compare it with the LPRF variation, you have your cells completely squeezed, damaged or explode, but also, and this is very important, a lower fibrin density. You see this picture has been taken at the same scale. And you can see immediately that here the fibrin mesh is much thicker than here. And this is very important because when people do not have a nice PRF, they also often observe that the clots are not so strong, and this is clearly visible here. Why? So here in the part 3, we evaluated the differences between the various PRF protocols. It means we use the good centrifuge, the traditional one, the German one, but we just changed the tubes and the protocol. So here actually the study was very simple because you just take the blood and make the centrifugation following the 2 protocols. Here, and after you see what's happened after 0 minutes, just after the centrifugation, 20 minutes, 40 minutes, 60 minutes. Okay? So this is the part 3 of this article. Here you have the clot when it's taken out of the tubes. In the upper part, you have the traditional LPRF obtained with the normal LPRF protocol, which is 2,700 RPM during 12 minutes, and it was done in a 9 milliliter blood tube. While the LPRF protocol is done with 1,500 RPM during 14 minutes, so this is a modified protocol, and it is done with 10 milliliter blood tubes. And the interesting thing is, whatever the way, you always have a very significant differences of the size of the clot. I mean, this is immediately visible, and I advise all those who have access to this tube to make the try. The difference is obvious. Then we try to analyze the growth factor release. So we did, in fact, the same study than the one we did a few years ago about the PRGF, the PRP membranes. We did a comparison between LPRF and LPRF membranes. The membranes were placed in culture, and we did the quantification at 20 minutes, 1 hour, 4 hours, 24 hours, 3, 5, and 7 days. And we analyzed actually 16 different kind of growth factors and molecules. And we after went to, but here I will show you just 4 results for TGF-beta1, PDGF-AB, VEGF, and BMP2. Actually, BMP2 is not something very significant in my opinion for this kind of products, but it is expected actually to be released by some activated leukocytes. So we just put this to the test, as it was some commercial statement about that. And what we observe actually is we have a very significant differences, not as strong as in the case of the PRGF, because PRP and PRF are very different. But here we see that the LPRF traditional protocol has always his normal curve during 7 days, while with the APRF protocol, actually, we have a lower quantity of TGF-beta 1, of PDGF-AB, same thing, LPRF, PRP, LPRF and APRF, so the normal protocol and the modified one. And also we observe that the class is dissolving after a little bit more than 3 days. It depends again the condition, but in these steps it was dissolving quite quickly. So after we put the same analysis for VEGF, we obtain the same kind of result. What is actually quite a logical. The clots are much smaller and in a completely different shape as the cells are damaged. But what is also very interesting is that for the BMP2, we had a little bit of release in the LPRF. The quantity are quite small because it's not really a factor that should be released so strongly by blood. But we can find a little bit with LPRF while we don't observe at all with the APRF. And the reason can be probably related to the state of the leukocytes. So now, what are the effects of LPRF on human cells? So here we are mostly talking about the literature on the topic. Again, it was already widely published, and about the in vitro effects of LPRF in primary cultures of fibroblasts, osteoblasts, preadipocytes, prekeratinocytes, etc. It was a work that was published a long time ago. So first, about the gingival fibroblasts, you see that you have a dose-dependent effect in most conditions of the PRF. Actually, this is not something very surprising, simply because in most cases, when you put some growth factors with fibroblasts, you are sure that you will have some proliferation. But at least it was validated in this article. The second one is about prekeratinocytes, and the same thing. It was published in 2009. And you have again this improvement, this increase of proliferations of prekeratinocyte in cell cultures in the presence of PRF. So, okay, the LPRF is increasing the proliferation of this kind of basic cells, which is very normal. What is a little bit more interesting and maybe surprising, it is when we start to speak about osteoblasts. First, we have a proliferation, an increase of the proliferation of osteoblasts in cell cultures. Here, this is also what you can see here. You see it was a dose-dependent effect. Here you have the control group, the test group, and the test group 2 PRF. And after 28 days, you still have this strong effect on osteoblast proliferation. But what was very surprising was that at the same time that we had a proliferation, we had also an increase of the alkaline phosphatase activity of the human osteoblast, which means that in fact we had simultaneously in the box proliferation and differentiation of the cells. This is what you can observe here, for example, after 28 days. Here you have your control group, you have your test group with PRF, and here after another condition, here you have your control group without PRF, and again test group with PRF here and here. And in each time you have an increase of the alkaline phosphatase activity and an increase of the differentiation. So we have simultaneously proliferation and differentiation, and it was very surprising because normally the cells, they cannot do both. And the reason why is simply that in the box, this photo also, you can find it in the article, we observe, you see, that after 28 days, control group, test group with PRF, control group, test group with PRF in 2 conditions. The darker it is, the more mineralization you have. So it is very visible. And in fact, as the box were very big, these plates were very big, we observed that, in fact, we had in this box simultaneously probably proliferation and differentiation simply because we had 2 kinds of behavior of the cells inside the box. It was the theory of this study. So The effect of the on osteoblasts are always associated with the beginning of mineralization of the PRF membrane. And also, this is also what was visible during this study. And when it was put in SEM, it was visible that there was a lot of lymphocytes, all these white cells everywhere. So we also, in this study, proposed that the result of stimulation of proliferation and differentiation of osteoblasts was associated with the presence of leukocytes all over the culture. So all that you can find in this article, but it was very important because we showed these multiple aspects of the culture with PRF. Now let's speak a little bit about clinical applications. And I want to thank my friends, Dr. Marco Del Corso from Turin, and also Dr. Vervel from Dohan, which are part of the really early group working on PRF since almost the beginning, particularly Dr. Vervel, who was there since really the beginning. So you can find a lot of a potential application in these two articles, which are very big, almost 30 pages each of them. And this you will find a considerable number of possible applications, and this is actually a very good basis to have some ideas. But let's speak about some basic stuff. First, for example, this case is one of the oldest cases done with LPRF. It was published actually only recently in 2012, but historically this is an interesting case because this is one of the oldest. And as you can see, in this case, it was extraction of a teeth. The cyst was removed very carefully, and the cavity was filled with PRF. This is how, in fact, all it started, with this kind of very basic application, filling this kind of cavities with significant bone defect to try to see how it was evolving. And here you see, after the reopening, the researcher observed that it was an interesting healing, a more comfortable surgical approach, actually. And this is how the PRF started to develop. At the same moment, was a lot of work about the sinus lift, because the sinus lift is a very interesting approach, a very interesting clinical application for PRF. It is a very good way also to have bone samples and try to evaluate how it can really improve healing. So this series of articles were published about that. And to make a summary of it, the first one, it was one of the oldest articles. It was, in fact, the impact, we tried to evaluate the impact of LPRF with allograft. In that time, the group of surgeons was trying to live 8 months actually without LPRF of maturation. And when they started to use PRF inside, they started to see, it was a relatively small series of cases, that they could reduce the time of bone regeneration to 4 months. So it is not a very significant article, but it was the first try, because in that time particularly, the bone material were not so efficient as it is now, even for allograft. So we had this first idea that the LPRF was very comfortable to use in sinus and could help in bone regeneration. Another article was published in 2008, where it was proposed by Dr. Dis particularly to use the LPRF during sinus floor augmentation, during Summers osteotomy. So here the idea was simply to use the PRF as some kind of pillow to compress, in fact, to do this sinus elevations. I mean, the PRF membrane is placed inside the small bone cavity, and it is then pushed with the osteotome to fill the sinus cavity. This is what you can see here. You see, after placement of the implants, you have the new position of the membrane, and the cavity is covered with PRF all over it. Sorry, the cavity is filled, with PRF was pushed during the sinus floor augmentation. So it's a very actually elegant way for a Summers osteotomy. Here you can see after 6 months, after 1 year, after the follow-up at 1 year, where you see the quite a natural bone regeneration. Actually, this approach is very easy, very, very comfortable. You can push the membrane, fill your cavity without any risk of having materials going in the sinus. So this simple approach was comforting us that PRF could be useful in many applications. Then came the idea, even if it's not used massively, to use only LPRF during lateral sinus lift. So this article, the first article was published by Dr. Mazor in 2009, where in fact together we did we did a study where we evaluated PRF as soil grafting material. So in fact, it was not only a radiological but also an histological study at 6 months. The objective of this study was to see what's happened when we just place our implants. You see, we lift the Schneiderian membrane, we place the implants to keep the Schneiderian membrane in high position, and after we just fill the cavity with PRF. Actually, this kind of study was already done by using just blood. So we knew very well that if you have a careful sinus lift, you can fill the cavity just with blood, and you have a quite good result. But it is true that if you can use PRF to cover the Schneiderian membrane and to fill the cavity, it's always more secure because you will improve at least the healing of the Schneiderian membrane, you will secure your site. So it was the idea. The cavity was filled with PRF, then covered with PRF membrane, and during the follow-up, at the end of 6 months, a bone sample was taken during the last phase of the treatment and placed to histology. And the histology actually showed that histology was taken laterally just at the level of the window. And it proves that, in fact, the cavity was completely regenerated with natural new bone just simply by maintaining the space. It means the implants are serving as 10 pegs and filling it with PRF. In this case, it was really the confirmation that PRF is an optimized blood clot. I mean, as it is exactly the definition. This is an optimized blood clot. Here it was after the work of a 6-year experience, where also I participated with Dr. Simon Piry, who did a slightly different approach in the sense that it was not an histologic study, but more a 6-year experience in complex cases. It was 2 surgeons in this study, Dr. Simon Piry and Dr. Del Corso. And you see here it is a first cases, who was published also in this article. You can find it inside, in implant dentistry, where you see it was a highly resorbed sinus. The membrane was even damaged, probably it was borderline, but as we will not use any bone material, it was not a problem. The membrane was covered with many PRF membranes, placed in high position and maintained in high position using the implants, and then covered with PRF membranes. And after the follow-up, as it was published also, after 20 days, you see that you have nothing in the sinus, just the implants are stabilized by the microthreads, and they are hidden and protected by the temporary bridge. And after 6 months, we can see already that the cavity is partially filled. After 4 years, we can see the level of the bone at the top of the sinus. So it is what was published in this kind of application with this kind of implants. For sure, it is not something that is so comfortable in the sense that people prefer to have a mix of material with PRF to have this space maintaining and to secure their site. But it proves you that, in fact, if you maintain correctly your sinus membrane in high position, the PRF is really helping to heal this area. And finally, this part, this last panel was published in this same article. It was, you see, with another implant system in the same kind of cases, with the implants are placed, maintaining the Schneiderian membrane and the PRF membrane in high position. It was filled with PRF clots, covered with PRF, and after you have the follow-up after 3 months and 3 years. So that is an important study. Personally speaking, I think that one of the biggest daily applications of LPRF, this is really the regeneration of peri-implant tissues when you have a graft associated with PRF. This case, I really like it a lot. It's a case was published in 2012, and it is really the perfect illustration of what PRF can bring you in your daily practice. Here you see it was extraction of a canine. The canine was damaged, infected. Okay. It had to be removed. But the problem is when we open, we have a big defect. The implant was placed carefully, blocked very well. And once you have your cavities, the problem is how to close this space, because when you take away the teeth, you have the hole, and the gingiva is not in good shape. In general, what is recommended, the traditional approach is to try to suture it and to close this area at all costs. But the advantage, but the problem of this approach is that if you do that, then you have to do a second surgery to put back the gingival line at the right level. When you use PRF, particularly it was shown a lot by Dr. Del Corso, since he has a long experience of that. In fact, you don't need this second surgical step in most cases. Here you see the implant was placed. The cavity was filled with a mix of PRF and bone material. Mixed like 50-50 or 66-33% of PRF with the adequate bone materials. But the more important is that at the end, the surgical site is completely covered with the PRF membrane, and the PRF membrane can stay outside. You see, we did not move the flap higher. Several layers of PRF were put to cover the surgical site, and the PRF is in contact with the oral cavity. Here we have the sutures, maintaining it very correctly, but nothing very complicated. The important is just that the material, the flap, and the PRF are stable. And here you have this follow-up, and this is very interesting because 48 hours, you see, first you have a phenomenon of induction. The gingiva start to be reddish and to start to grow like a new tissue, like reactivated tissue all over. And in the center, you have the PRF membrane, the external layer, which is becoming whitish. It's normal. It is in contact with the oral cavity. It is addressed by the saliva, by the bacteria, but it is still completely present, in good shape, and it is still protecting the area. After 7 days, when you have removed the sutures, and you see that you have this phenomenon, very good healing, a phenomenon of induction still present all over the gingiva. And when you do your follow-up after 12 days, and during the following time, you finish to have an excellent gingival healing, and you did not need a second step surgery. Simply because the PRF not only inducted a very strong and positive gingival healing, but also avoided you to do this second surgery, as you are able to close the surgical sites just without tracting the flap, just thanks to the PRF. Your final result is okay without the need of having a second surgical time. I will show you also another technique was proposed by Dr. Del Corso, and we published it together in 2012 in the Journal of Oral Implantology. It is the idea of the L-PRF and immediate implantation and gingival maturation. I will explain. Here we have extraction implantation, placement of the abutments, and we know that the gingival healing can always be tricky. We can have some resorption, some recession. So the PRF membrane was punched around the abutments and stabilized here with the crown. And when you do after the follow-up, after 2 days, you see your PRF membrane was not sutured. The PRF membrane was just blocked in position by the crown. You see this whitish aspect here. After 2 days, okay, with the aggression of the oral cavity, it looks whitish, but it's still here in perfect shape, making a perfect sealing of this area. After 7 days, okay, it's starting to be resolved. The gingiva is already well healed, the nice aspect, and you still have a little bit this whitish of the PRF. Still, no problem. The healing is okay. Finally, when you have your follow-up after 3 months, and after 2 years, 6 months and 2 years, when you go to the final ceramic, what is very interesting is, first you have an uneventful healing. Look at here, this area. You have an uneventful healing, but you see that this area will continue to evolve with time. Not yet at 6 months. You can see that the gingiva has evolved. It's becoming thicker. And at 2 years, after the follow-up, after the positioning of the ceramic, you will have this thicker and also this growth of this area. There was a small defect. The defect has disappeared. So in fact, with a mini application of PRF, particularly at different step, you will have an induction process and an evolution of the tissue. You are in fact programming an evolution. This is very interesting. I will show you, to finish this webinar, a few other applications, because there are thousands of possible applications, not only in dentistry. First, this article that we published in 2008 about the use of PRF during subtotal parotidectomy. It is like plastic surgery, let's say, application. During a parotidectomy, we have a double problem, which is, first, we want to avoid a cavity to exist and to create a defect which is visible in the face of the patients when the parotid gland is removed. And the second, we want to try to avoid the wrong healing where the nerve is going to connect to the skin. So we need a material for filling the cavity and interposition. Here you see the PRF clots were placed here to fill the cavity after parotidectomy. And after, we follow this patient and we try to evaluate what we call the Frey syndrome. This Frey syndrome, it is when the nerve is going to connect to the skin, and these patients, each time they are hungry and they have some saliva coming, they also are sweating. When we use the PRF as this filling and interposition material, we had in fact no Frey syndrome. So it is a very easy but very useful application, very inexpensive and efficient applications to fill this kind of maxillofacial or plastic defect. Another kind of application we published with my colleague, Professor Zumstein from Bern, it is in sports medicine. And he's actually doing a lot of efforts to place PRF membranes in different conditions. Here you see the placement of LPRF clots during rotator cuff repair. Here, LPRF clots during anterior cruciate ligament repair, or during here knee dislocation. Applications are many. The main problem of the PRF in comparison to the PRPs is that it cannot be injected so easily. PRP can be injected. Per definition, they are liquid. All platelet concentrates which are liquid are PRPs. So they can be used more easily in sports medicine. But in fact, as you can see, we are working very also actively in sports medicine to see how we can place these PRF membranes and clots in these different kind of applications. It is a very interesting topic. And I would like to finish this presentation to explain you that PRF is not magic. Some people working in this field are using it as a commercial argument to explain you that it will maybe change the world, or that there is a kind of magic mechanism behind. This is not the case. PRF is an optimized blood clot, and you can do a lot with an optimized blood clot. But you shall never forget that what is important is how you use it and how you combine it. Not only with other materials, but also sometimes with other healing biotechnologies. For example, I work with another technology, healing biotechnology called ginginat. You see this kind of mouthwash and gel. This is a macro-encapsulated natural extract. It's completely unnatural. And this is a product which is helping healing, antiseptic, antioxidant. Okay? It is something that is not available in Germany, but we have it in France since 2006. We mostly sell it to our colleagues to continue to validate it. And in fact, we did this study when we started to evaluate it on the skin rabbits. We had 4 wounds. We compare ginginat, a fibrin glue, a L-PRF, here with the sutures, and a control. And clearly, the control was not so wonderful. The fibrin glue was improving something. The PRF had a good healing. The only problem was the removal of the sutures in this case. But the one who gave us the best result, and we were very surprised actually, it was this ginginat. So this example shows you that when you are considering these kind of materials, you must have a global vision on how you combine it. How you combine LPRF with bone substitutes, how you combine it with the adequate membrane sometime when it is a complex surgery, with the adequate also sutures, with the adequate here mouthwash and gel. It is a more general approach of biotechnology applied for regenerative medicine strategy. So, as a conclusion about PRF, yes, so old, so new as you have seen, this is something, the LPRF, that exists since 15 years. And, but in fact, we have still so much things to do with it. The first important thing is to remember this is not a classical biomaterial. It must be understood and manipulated as an autologous tissue graft. This is a tissue. This is a membrane with cell, which is a matrix with cells, with growth factors. This is a tissue. It must be respected and manipulated like a tissue. If you want to have the best regenerative medicine or tissue engineering result, you must manipulate it like you would manipulate all kinds of other tissue graft you could use. The applications are endless, and as you have understood, they need to be validated very carefully in all configurations. And what is also very important is that this machine, this PRF system, is changing completely the approach of complex surgeries. Me, I'm from the PRF generation, actually. So when I am hearing some problem of gingival dehiscences or this kind of problem we had before with the GBR, it's something that I don't really perceive or understand because I was never placed in this situation. So the era of LPRF is completely changing the approach of complex surgery, but still, it requires to know its strengths and its limits and how you associate it with other technologies. Optimized implants, optimized bone materials, optimized membrane, and as you can see, also mouthwash. So many stuff will be published also in the Poseido journal. Not actually the last article about the growth factors, it will be in another journal, but you will find a lot of clinical things in this open access journal. I give you here the website address, poseido.info for the open access journal, poseido.net for the foundation and organization. And it is open access, and you will see we have a lot of things coming about PRF, about LPRF. And also, I will ask you, for all those who are following me since the beginning, it would be very nice if you can go to our Facebook page to actually follow us and like us. Actually, we are just starting now this activity, and it would be very welcome for us if you can continue to follow us, because we have many things coming about LPRF and surface. I thank you for your attention. So now we will see the questions. We have actually one question only, which is, could PRF be used in case of oral submucous fibrosis? Actually, I am not 100% sure of the question. In general, PRF can be used in all situations where you want to improve the healing. In theory, when you have a problem of fibrosis, you have to reactivate the tissue, so the use of PRF could be possible. Actually, there is no risk. You have to imagine that PRF is just an optimized blood clot. So each time you are in any way provoking some kind of bleeding to improve the healing, the PRF can be used. But this is something in which I have actually not experience. I have another question here. In Ganati et al. Articles on LPRF, it states that there is presence of more number of cells compared to LPRF. What have you noticed in your studies? Actually, indeed, I have seen this article, which actually does not really prove anything. But in fact, the problem is how you evaluate the cells. It means even if cells are damaged, I suspect, because I suspect the reason of what they observe is if you do just photonic staining, basic histology, you will maybe see cells, you will maybe perceive that they're a bit damaged, but you cannot visualize it as well as when you are with SEM. So in our studies, actually, we pushed the analysis very, very far. And when you do just photonic microscopy, okay, you see black spots corresponding to the nuclei of what remains from cells. But if you go a bit deeper and analyze, observe how they look like, you see that they are completely shrinked and damaged. So I suspect the reason between the difference between the two studies is because we went much further. But we have also done the photonic study, so we have all this picture and it will be published. Another question. Have you used LPRF in application for root coverage? Actually, for me, the biggest expert in that, this is Dr. Del Corso. He's working on that since, maybe 9 years now. And we are supposed to publish his results because he has done a considerable work on that since several years. So yes, it works very well. Yes, it is a very interesting approach. but it requires to have a good protocol because there are many possible protocols, and there are also many ways to use it. And depending on the ways, you will have different kind of results. So yes, it's a very good application. Yes, it has been already widely studied by many people, even if we are lacking an extended list of publication about that. It will come soon, but for now, I'm sorry, I cannot say much more. So I have another question here. Okay, can PRF be used as a soil material for socket preservation? Yes. So yes, for sure. Actually, it is. I mean, this is probably the best thing you can place in a socket preservation area. This is a natural blood clot. The main problem of this approach, the only problem actually of this approach, is just to maintain space. It means it is like for sinus lift. If you want to have a good bone regeneration, whatever the place, you must maintain the space. So in general, when you have a very basic extraction and you want to preserve your socket, you just want to have a better healing. You just put PRF, it's enough. If you have all your walls, but as soon as the cavity is a bit infected or infected, as soon as the cavity is a little bit damaged and you have some walls missing, in general, most of us, we are mixing a little PRF with some material, a little bit of material, like half. I mean, after it depends mostly on the size and the kind of defect. But it can work alone very well as a condition you are able to maintain the space. So another question here. Okay, so is one potential application to close furcation? Actually, we published a few cases actually in periodontology in this kind of situation. In general, the PRF will improve healing. So when you have this kind of damaged furcation, it will be always the same treatment, which is a kind of filling of the cavity, cleaning and filling. And the PRF can for sure improve the healing and improve the healing and the regeneration. But there is no real consensus yet on which protocol in which condition. So, but it works. I mean, you can use it everywhere. So what I have here. Okay, so I have one question. We use PRF to cover implants in peri-implantitis treatment. Okay, so peri-implantitis is a quite complex topic because when you see the literature, you see that no one is really completely agreed on what is the reason, what is the mechanism, because it's multifactorial. It depends also on the kind of implant design, on implant surface. So it's a very wide question. What is sure is that if you try to save your implants who has a peri-implantitis, whatever the kind of treatment you use, to add PRF during your surgery can only be beneficial. First, because it's improving the healing, improving the soft tissue healing, improving a little bit the bone tissue healing also in this kind of area. After, the problem is there are so many parameters related to peri-implantitis process that there is no one answer. But for sure, if you really want to try to save your implants because you think it's savable, the PRF will help you, for sure. I have another question here. How important is the angulation of the tubes while centrifuging? Most of the centrifuge systems have a split rotor having 90 degrees angulation. Also, could you tell us about the RCF force, which seems to be an important part of the centrifugation? In fact, this is a quite complex question. The angulation process, the angulation of the tube is actually indeed quite important, but it does not mean at all that you need to have a 90 degree. Actually, one of the characteristics of the PRF is because we use this partial angle, actually. We have this, in fact, two areas. One area with a lot of cells, while if we in one area with less cells. But I mean the organization of the membrane, it was like that since the beginning. And if we use 90 degree, in fact, we change completely the concentration of cells, and we have something which is a little bit less efficient. It's a little bit complicated to answer like that just in a few seconds, but let's say that the reason why we are still using after 15 years this stable centrifuge is because it is much more actually efficient. And concerning the forces of the gravitation force we are using, the problem is not only the force. For sure, if you don't use enough force, you will not have enough centrifugation and separation. It means you will not have the same cell composition of the clot. You will not have the same concentration of fibrinogen and fibrin. So there is anyway a minimum force to use. And the other thing is that the leukocytes activation is also dependent on this force. So in fact, it is something that was observed empirically at the beginning, and in fact afterwards validated by the experience, which is the force we are using with the initial machine seems to be actually the one giving one of the best clot. And the other part is that the centrifugation force is one problem, but the important step of the important problem of the vibration is also very important. And last question, it will be the last for tonight. So thank you. What is a certain centrifuge model that do you recommend? Well, me, I can only recommend you to use the traditional German machine we were using since the beginning, because from all what we have tested, this is simply the best one. This is not really more expensive, and we had never any problem, and we are sure because we have tested that there are no vibrations. So me, I find a little bit absurd. We had this problem at the beginning of the PRF. Many friends, they wanted to try to save a few dollars by buying online some machine made in China, and after they had problems, they never had the nice clots, they never had the right nice membrane, and they were complaining about the technique, while in fact what we discovered 10 years later that it was in fact really the problem of the machine. So this traditional German model, actually, who is now labeled as intraspin system, is the only one I can recommend you, and actually this is the only one which is a certified material in Europe and US. That's all. So, well, I will thank you very much for participating, and I hope my presentation helped you to understand the strengths and the future of this technique. And I hope to see you, maybe all of you, one day in face-to-face lecture in the future. Thank you.
Thank you very much, Professor Ehrenfest, for sharing your lecture and your insightful information with us. We'd also like to thank botiss for making this online course possible. And thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You'll receive an email notification with the link to the recording. Further questions for Professor Ehrenfest may be submitted directly on the website, on the courses page, under the Ask the Expert tab. So please go ahead and submit your questions, and Professor Ehrenfest will be sure to get back to you as soon as possible. Please be sure to visit the botiss educational platform, www.botissacademy.com, and keep an eye out for our growing schedule of online courses. Thank you again to all, take care, and goodbye.